Welcome, everybody. We are here on Plastic Surgery Untold to talk about facial feminization. This is a really fascinating topic. We have about 30 to 40 minutes, so it's just going to be like an appetizer sampling of it. Before we get to it, why don't we talk about what's new? Travis?
What's up, you guys? We're back in the studio with another one. What's up? Well, this week, my wife is out of town. So she went on a little girls' trip to Miami. And before she left, and they're staying in South Beach. Before they left, she goes, "Yeah, we're gonna go to Miami. I need just like a little bit of time to like relax and just chill." I was like, "And y'all are going to South Beach? Like, I mean, that sounds more like
super
like
low key.
So I guess
Montana
very low key right there.
cabin kind of trip."
So I guess the important question is, when's the boys' trip to South Beach? Because this seems to be coming
to
up
relax
soon.
as well.
to rest and relax, to recharge. So anyway, she's out there right now, having a good time with one of her friends from college. So she, I'm hoping, comes back rested and refreshed. And ready.
That's interesting. You said no one. It's like South Beach in Vegas.
Yeah.
I've never been so well rested in my life. So, Dr. Franco, other than enjoying some mini Coke Zeros in glass bottles, what have you been up to?
Ooh, lots of stuff. It's honestly been super exciting. As you guys know, we recently opened our San Antonio office. We also have a little Best of Austin award ceremony coming up. So hopefully we got some good news for you guys shortly. So that's been a bunch of our stuff and super exciting. There's another nugget that we have coming, but can't tell you guys about it quite yet.
Speaking of super exciting, we have our two latest additions, our two new partners, and we're going to start with Dr. Arredando.
Hi. Hey, guys. Glad to be here. Thanks for having me on the podcast. Life's been good. We've just been getting used to Austin and the 110-degree weather.
Oh, my gosh. Yeah.
That's a bit of an adjustment.
Yeah.
And because your wife's a physician here in Austin as well.
She is. She'll be at the Children's Hospital doing her neurology thing.
Cool.
And so we start almost exactly the same time.
Yeah.
I start a little bit later because I've got a better boss. You
know?
So that's
He
worked
says
out
that
well.
now.
So, quick, on a scale of 1 to 10, how did I do with your name?
Oh, that's about, I'd say 9.5.
Shut up,
That's
dude.
strong.
Are you serious?
That's
awesome.
strong.
Yeah.
Strong.
Yeah.
Wow.
Okay.
Tough.
You
I
can't
like
say 10 because, you still...
Yeah.
Yeah.
can still
Well, you
always
don't
do
want. I
better.
want to be able to
Can
get
always
out
do
of
better.
the. Yeah. Okay, Dr. McLiff.
So not much has been going on. My wife is out of town this week. She's in Chicago selling our wine importing and distribution business. So
Nice.
that's exciting.
I think congratulations.
Thank you very much. Appreciate it. So that's hopefully going well.
Yeah.
We will see tonight when she gets back. But
Yeah.
otherwise, super exciting things. We recently opened San Antonio. It's been fantastic. We've been seeing consults there. Super excited to see where everything goes.
Quick tangent. I know you said you had some other endeavors in addition to the wine business. So what are the focus of, let's say, at least one of them so we get to know you a little bit better?
Yeah, so I also own a real estate company as
Oh,
well.
awesome.
So,
Very cool.
yeah.
All right.
Which is a little bit of a sensitive subject here in Austin for anyone who's been doing some price. So it's not Austin.
It's not Austin.
Okay,
No.
so just don't want people to be upset at you.
That's right. Yeah.
What about you?
Well, I've been spending a little bit of the morning learning about the history of facial feminization, and I found out some really interesting topics, some interesting facts. Does anybody want to take a guess as to when facial feminization started as a practice, as a field of medicine, of surgery?
1960s.
century.
Okay.
I'm gonna say 70s.
Okay.
Ooh, I was gonna say 60s.
Yeah.
I said 19th
I
century.
said 60s.
19th century. Okay.
I was gonna say
All right. So, according to Wikipedia, which isn't always, the end all be all.
Which we're fighting with now because they took our Austin Plastic Surgeon Wikipedia page down, which we're still protesting. So anybody listening has to pull Wikipedia, put in a good word for us.
Oh yeah.
I'll message them this week.
And I donated to them recently too. Okay. All right. Maybe it's because the donation wasn't that big. I don't know. All right. So, so according to a website that has information, it started in 1982. Now, I'm sure
Okay.
there were like little, drips and drabs of procedures before that. But I think what what this website was talking about is that one of the most powerful procedures that we do in facial feminization, that is recontouring the forehead and specifically addressing the large amount of bone, the brow, frontal bone bossing, or the large bone that sticks out beneath the eyebrows, that the first time that was approached for the purpose of feminizing someone's face was in 1982 by a Dr. Austerhout, who I think was in San Francisco at the time. Someone who did, I think it was probably genital reassignment surgery, had a patient who was a female trans woman who wanted to have facial feminization. That really apparently is the time that it really began.
Very
And
interesting.
the thing that I think is so cool, though, and because I don't want people to misunderstand, is, basically putting these procedures into a structure for this purpose. But a lot of the techniques have evolved from stuff that we've done for years and years, whether it be from traumas, whether they be from other congenital shaping, because there's lots of stuff where we have to reshape the skull, the face stuff, but typically not with this focus and maybe aesthetic mind.
Correct. Yeah, and we need to talk about that real briefly, because that's important. But in a minute, I think it's really important, just so that we do this right. We got to talk a little bit about nomenclature, so like what we call certain things, and then I think it's also important to have a little bit of like a disclaimer. So the language and the concepts that we use to talk about gender affirming surgery, about people who are transgender or even non-binary, that language is always evolving. And so if we use terminology in a way that is inaccurate or doesn't reflect how people feel most comfortable, it's totally unintentional. I think it's a really important disclaimer, because these populations of people, rightfully so, want to have respect. And so if we make an error, it's not out of disrespect. So then on to nomenclature. So, and there's so much that we could talk about, but let's talk about about 6 to 8 terms, right? So, one, when we talk about, what someone, let's say, looks like coming out of the womb, right? If they have a male body, like a penis, things like that, we say that they're assigned male at birth, right? So assigned male at birth, absence of penis, we would in a vagina and what have you. We say assigned female at birth, right? Just to say that. But that isn't necessarily, that's very specifically not talking about gender, because many people who are transgender would say, well, my anatomy or who and what I was at birth doesn't define who I am in a gender spectrum. So that's important. So assigned male, assigned female at birth. And I think it's important that we kind of have that, because it'll make some of our discussion subsequently less cumbersome. So if you have someone who is assigned male at birth, but always has known internally, always has felt, always has identified as a female, so again, assigned male at birth, but they know truly they're a female, we would call that person, or they would self-identify as a trans woman or trans female. Same is true if you have someone who is born, let's quote unquote, as a female, really, but we're avoiding using that term because that's really a gender term. But if we're talking about their anatomy, even potentially some of their genetics, we're saying that they were assigned female at birth. If that person, as they're developing, as they're growing, as they're getting to understand who they are, if they feel like they're a male, they're going to call themselves, and we should, out of respect, call them a trans male or a trans man. So then just one other piece of terminology, or couple, is that, so if you, let's say, are assigned male at birth and you identify as male, then the terminology that's used to address that person is cis male. And that how we come up with that terminology is kind of interesting. I'm not going to go into that because it's like a whole chemistry lesson. But essentially that's to distinguish a trans male from a female, a trans male from a cis male. So cis male, again, assigned male at birth and feels like they are who they were assigned at birth. And then the same goes for cis female. And so that's important to talk about, because I've learned along the way that you can kind of say things that, of course, you don't intend to say, that can, someone can find a little sensitive or offensive. But once you start to understand the terminology, and so the process of helping someone feel and look like they know they are is called gender affirming surgery, and facial feminization is one of the most wonderful aspects that we as plastic surgeons and as Travis as a anesthesia provider can be involved with the overall care of these patients to help them, to affirm them and have them feel and pass in the world as the gender that they know they truly are. So I'm exhausted. What questions you guys have now?
I think that you brought up so many good points, because one, I think we all want to help people reach their aesthetic goals, and there's lots of things what that means, like you're stating. And I think sometimes we do misspeak, and I've definitely been guilty of that, but it's not out of malice. I mean,
Yeah.
sometimes it's just either lack of understanding, or sometimes just a mislip of speech
Yeah.
more than anything else. So I
Yeah.
think those are super valid points.
Oh, and I know where we were. You had brought up a really important point, and that is that almost none of these procedures are actually new. They are all things that we did in the past, mostly as part of reconstructive surgery and some cosmetic surgery. So that there are things that we did in the past, or they are modifications of things that we did in the past that are brought together as part of a basket of goods that we can offer to our patients under the umbrella of facial feminization. And one of the best ways to think about this and help sorting out this with patients is to really break the face up into thirds. So you've got the upper third, the middle third, and the lower third. And I'm going to briefly highlight sort of what we're focused on, and then I think we should have everybody who's been involved with this, probably talk a little bit about their experience. But if we talk about the upper third, we're talking about the appearance of the forehead, the brows,
Just so,
even the
so people
temples.
understand, because when you talk about facial feminization, this is a broad term that encompasses multiple procedures.
Multiple
'Cause
procedures.
Sometimes people say, "Oh, I want
Dozens of
facial
procedures.
feminization," but then this is where we have to work with you to be like, "Okay, what does that mean to you? What specifically?" It's sort of like when people use the term "mommy makeover." There's a lot of procedures that can fall inside of that, and it really depends on person to person.
Yeah, and I will say that the women, the trans women who come to see me for these procedures, actually they kind of make it easy on me most of the time, because a lot of them have there's some they're obviously really passionate about is their identity, right? And so they've spent a lot of time researching this, and so when we start to they often know what they want done in the upper third, the middle third, the lower third, and I just use this concept of talking. It's not my concept at all, but breaking things down into thirds to keep us organized. So we've got the forehead, the brows, the hairline, the temples, and the shape of the orbit as the upper third. Middle third, you've got the cheeks, you've got the nose, you've got the cheek, really the cheekbone, fullness in the cheek, and then the upper lip length. And then the lower third, you have essentially the fullness of the lips, the size and the projection of the jaw, and then also the jaw, meaning the chin, and then also the side portions of the jaw called the gonial angles. And then also there's sort of like the fourth third, the neck. And there's some things that we can do in the neck as well. So I know we were talking about this beforehand. You guys have some experience with this. Do you guys want to talk about, is there a third that you guys would like to talk about at all? Not to put you on the spot, but are there, or just a particular procedure that you guys have enjoyed doing?
I've enjoyed the one that I've done the most commonly has been addressing frontal bossing or the brow ridge, and I think those are pretty interesting procedures. I would have a question for you though. We used to get a lot of imaging for these, like CT scans, so we know the thickness of the anterior frontal plate. Do you tend to get CT scans for your patients if you're addressing that issue?
Yeah, absolutely. I do absolutely, and there's been an evolution in the way that I have done things and how I've sort of a lot of my practice actually has migrated into this work, and I absolutely get CT scans now. And what you're referring to is that there are two different procedures, at least what I believe you're referring to. There's two different procedures that we can do in the forehead in order to decrease one of the things that is perhaps the most masculine component of our facial appearance. In fact, there are studies that demonstrate, like physical anthropology studies that demonstrate that one of the things that's, let's say, the biggest identifier as masculine is the bump here that we have. That most men have that is pretty full, that's either just under or above our eyebrows. And so what you're referring to is, how do we address that bump? How do we get rid of that biggest tell, if you will? And there's two ways to go about it. One way is to burr it down. Well, actually, there's three ways, but one way is to burr it down. One is to camouflage it by placing something in the valley, if you will, above it. And then the other way is to cut the bone that creates that and set it back. Yeah. And so imaging can be really helpful for that. And so the way that I found imaging to be helpful is that one, you can use it in combination to your physical exam to know if there's a significant degree of thickness to that bone that you can merely burr it down without getting into the frontal sinus, which can cause some problems. So if you can do that, that's great. And the reason that that's great is because then you don't have to make some cuts into the bone, which it's not hazardous in any way, but it is a little bit more time consuming. Well, I should say it's never safe to say. It's never right to say it's not hazardous in any way. What I meant to say is there's not a significant amount of hazard to doing that.
Right.
But it does, if you can just burr down the bone, that's a more simple procedure.
Right, but you have to have that thickness of that bone.
You
to
have
be
to have
able
that thickness, and the imaging is helpful for that. Another thing to know is if they have a fully developed frontal sinus. I mean, some people may have, you may think based on the degree of projection, this is a patient I'd really like to set them back, but you might have one side of their frontal sinus that actually isn't a sinus at all. It's just thick, it's full bone. And that's a patient that you're going to have to burr down at least that portion because there's nothing to cut into to set it back. So you may have to split it, cut the one portion, set that back, and just burr the other side.
And when, sorry to interrupt, but when you say to burr down, for people at home that don't know exactly what that means, could you explain?
Oh, yeah. Thank you. Yeah, that's it's a rotating instrument that has a round knob at the end of it that has little grooves in it that chips away the bone in an incremental and controlled fashion. Whereas cutting the bone is literally cutting the bone, disconnecting a portion of it, placing it back, and using some plates to
secure it.
Yeah. So, to address your question, when I talked about an evolution, one of the early patients that I did facial feminization on was someone who had, oh gosh, we could spend the whole session talking about the upper third, but was a patient who had a low hairline. So, one of the things that, distinguishes a masculine from a feminine face is that with a masculine face, sometimes the hairline is receded, even if they haven't lost hair, whereas the height of a feminine face or feminine forehead is a little bit lower. So one of the things that sometimes when we're talking about the upper third with patients that we do is we advance the hairline. But in patients who don't actually need that, so a trans female who actually has, a feminine hairline, there's no need to make that incision at the hairline to advance the hairline. And that incision is one of the ways in which you have open access to that forehead, that frontal bone bossing, to burr it. Let's say if it's a patient that a CT scan demonstrates that you actually don't need to actually cut the bone and push it back. Another way is to place a cut across the hair, a couple finger breadths, a couple inches back into the hair and make a cut from side to side, essentially from ear to ear. Well, that's great because you don't have an incision at the hairline, but in some ways these patients almost always want a brow lift. So then you're pulling you're pulling the hairline back a little bit, which some patients can tolerate. Well, this first or second patient that I started to think about doing, how do I recontour their forehead? She had a minimal amount of bossing, but enough that she definitely would benefit from removing it. Perfect hairline. So what I did actually was I addressed it endoscopically.
Oh,
yeah.
nice.
I
Okay.
used one of those small joint shavers, and I did it as I would do an endoscopic brow lift. But that was actually before I started CT scanning them, and I was just extremely careful about how much I would burr down.
little by little.
Little by little, and as you guys know, the endoscope does magnify things. So you can kind of get a sense for if you start to see a little bit of, sort of like a darkness.
Through,
that
you're
you're,
getting close to the
to
sinus.
stop. Yeah.
Yep.
And so that's actually one of the first ways that I addressed forehead contouring in a trans woman. Come to find out, I don't think that's been actually done before. So we actually have an IRB to publish, my experience with it. But subsequent to that, I started to do imaging to answer your question. I've started to set them back. But like I said, we could talk so much about this because it's like a game of chess just to think about how to address the upper
Where do you
third.
start? Yeah. How do
Do
you?
you,
Yeah.
do
Where do you
you
approach?
think you guys, because we could definitely, have an episode over each of these, and maybe we need to come back and address some of these in length. But what if we listed the procedures kind of from top down, like
Yeah.
hairline, boss, and stuff? Because that way, at least today, people can get a big picture of the overall procedures, maybe a little highlight, and then definitely some of these that are super common, come back and
Yeah.
spend a little bit more time. Because I don't,
Yeah.
I think there's a lot of people that don't even understand all the options out there for
Yeah.
them.
Yep.
Yeah. Well, I could go a mile a minute and like take up the whole podcast. I insist that we have other people talk about it. So
Well, I can definitely tell
yeah.
you go over some of these procedures for sure. As you said, there's a ton of procedures that fall under facial feminization surgery. But starting at the top, we typically talk about hairline advancement. This is typical for trans female. Trans female. There's also potential for a little bit of hair transplant in these patients as well. In particular, if we have to put a scar in order to advance the hairline, we typically will go back and do some hair transplant over that location as well.
yeah. Oh, go ahead.
Oh, go-
Yeah,
no,
please.
please.
Yeah. Yeah. Keep going.
We can address the frontal bossing that we essentially just talked about in multiple different fashions. In a trans female, we want to change the position of the lateral brow and change the shape of the brow. And so typically we want to do a brow lift for these for the trans males in order to get the lateral brow up and change it so it's more respective of a male's brow contour.
And sometimes you have to be careful with brows because, in general, sometimes people have played with their brows in terms of their shaping, the aesthetics that people have done in terms of. There's all sorts of different brow like hair type things and shaping and tattooing. So I think
Yeah.
sometimes you got to be a little careful because they may already have artificially changed some of those shape stuff.
Yeah.
So,
Absolutely.
And to add what you said, there are a couple of other subtle things that are really helpful. So typically, if someone has more of a hollow temple, more of a concave temple, that kind of leans a little bit more masculine on the gender spectrum of facial appearance. So one of the really easy ways to address that is fat grafting to the temples. Another thing is that what's considered more of a masculine orbit is perhaps a little bit straight across when you think about the overall shape of it, whereas more of a feminine orbit has a little bit of a tilt up and sort of out. And so if we're doing an open procedure for brow contouring, brow bone or frontal bone contouring, we'll also burr out a little bit of the upper outer orbit, and that helps really reconfigure
Like
and
a
soften.
positive canthal tilt. kind of.
Yeah, exactly. Thank you. Positive canthal tilt. Yeah, and so that can be really helpful as well. You can't really do that well as a closed procedure, and that's where there's a lot of like give and take and a discussion with patients. When I meet with these patients, often it's at least a half an hour discussion where it could take an hour and a half, and I meet with these patients multiple times because there's so much to discuss. So anyway, so we've got the hairline advancement, we've got as you said for the trans women, also elevating the brow, so a brow lift. We've got fat grafting to the temples. I also especially if I'm only burring down the bone, I will always, before I lift up the skin to burr down the bone, whether it be endoscopically or with a full open procedure, I'll actually fat graft in the skin above where the brow bone was going to be, because you like, even if you have a CT scan, you have thick bone, sometimes you're a little bit sheepish about burring down too much of the bone. But if you do a little bit of fat grafting in the valley above that mountain of bone, then you've
You camouflage that transition.
yeah, you've camouflaged that transition. But not only that, some of the patients that I've seen from other really amazing surgeons tend to have a little bit of a flat appearance. And to do that little bit of fat grafting does help give a little bit more of a rounded, gentle, definitely just a more feminine look to it. So that's really the upper third in a nutshell. There's some sort of one-off things that you do for some procedures, and then when we talked about the middle third, we talk about the cheek. Let's break up the cheek sort of into the cheekbone and then the fleshy cheek, and then we have the nose and lip length. Does anybody want to comment about these?
Because I think cheeks is one of these that hits home for a lot of people, because that's something that we do very common, and some of those are changed with lots of things, and also unfortunately, you still have to take in the natural aging, which changes some of this because
Mhm.
for a lot of people, it's a little while in life before they're able to make some of these changes. And some of it, I think, is lifestyle. Some of it is cost, and it's a discussion for another day of what gets covered, what doesn't. And that's
Yeah.
an always evolving and
Yeah.
unfortunately a little bit of amazing hardness. And I think going to be probably a transition for a little while, but discussion for another day because we
Yeah.
could spend a whole episode on just that,
Yeah.
unfortunately. But I think working on the cheeks, the mid face, because there's a lot of procedures here, but it's I think more challenging, especially the older you get, because now you have to take into account not only the gender differences in trying to make this facial, but now also dealing with some of the facial aging, the ptosis of the skin, ptosis of these fat pads. And so I think some of that evolves a little bit depending on the age at which somebody has some of these procedures. And the
Yeah.
cheeks more than the forehead. Hairline, obviously, the older
Yeah.
we get, that can be an issue
Yeah.
as well.
Yeah, yeah, and I thought of a sort of a concept that I'm always mindful of, but when we think of a face, sort of a more masculine appearance, again in a masculine feminine spectrum of facial appearance, a face that we would consider more masculine, also is a little bit bottom heavy, whereas a female face is a little bit top heavy. So, and when I say top heavy, what I mean is perhaps a little bit more fullness, again, like in the temples, that sort of bitemporal distance and fullness, sort of rounded, but sort of more fuller features in the cheeks as well, and then a smaller jaw. Whereas in a man, the jaw is a little bit bigger. And so one of the things we can do to shift volume, we talked about a little bit of fat grafting to the temples, but adding to the cheek, whether it be fat grafting or whether it be cheek implants. And I'm not a big fan of huge cheek implants because I think they can look really artificial, but even a very small cheek implant can help supplement some of that upper half facial volume and can tilt that balance of being a little bit top heavy versus being bottom heavy. And then you add to that, you supplement to that, reducing from the lower half of the face. And that's where we kind of get back to that middle third. Buccal fat pad reduction is something that often is helpful in reducing the fullness in the lower half of the face. And then we do things to the chin and the rest of the jaw to make it less bulky, less full, less masculine, more feminine, and that's where you have your procedures such as genioplasties, where you can set the chin back, removing a small wedge of bone, setting the chin proper back, placing it back together with screws and plates, or even just burring the bone can be helpful as well. Frankly, when you do set the chin back in a true osteoplastic genioplasty, you still need to burr the bone of the chin because a masculine chin, if you will, has two little tubercles, so two little bumps, whereas a chin that's considered more feminine is a little bit more rounded. So even if you set the chin back and made it sort of smaller in an anterior to posterior projection sense, it still may have the two little tubercles. So often, if I'm doing a genioplasty, I'll burr those back as well. But yeah, it's one of those. It's one of those, facial feminization as an event for a patient and thus for a surgeon often is an all-day surgery. So, 7.5 to 8 hours. And it is a lot of stuff. So many of these patients, as you can imagine, they've been waiting for like years and years and years to look the way they feel and the way they see themselves, and they want it all done at once, and we do our best to do that for them.
I think one point to mention, we've listed, all these different procedures, and there's stereotypical norms for what appears female, what appears male. That's not the same for everybody.
Yep.
Somebody may identify as female, but they see themselves with a more square jaw. They may see themselves, with a higher hairline. That's okay. Not everybody's built the same. Not everybody's made the same. And so kind of our job with all those preoperative consultations is to sort of make sure that we understand each other and are on the same page before we're taking on this long, arduous, this long list of procedures, and making sure that what they see is what we achieve in the end.
And there's
That's
also
right,
some
yeah.
other options in terms of facial fillers, other things, because to your point, the recovery is not overnight for this. And so,
No.
this is definitely, it's a big change. It's a big time. It's a big commitment. So there's definitely a lot of patients that we have that do some of this with some facial fillers, definitely can achieve some of the same results, but there's fillers, some things in terms of some of the temple hollowing, some of the cheek animation, some of the jawline stuff that can help, bridge the gap for a little while, maybe just from a resource standpoint, maybe maybe it's not on your cards right this second from a time off work or lifestyle, family stuff. There's a lot of factors, and so I don't want people to feel like if you can't undergo this massive surgery, there's no options to try and get you to a good spot. There's a spectrum of stuff. Maybe like most things won't be as dramatic, but there's definitely some options for people.
Yeah, it certainly allows one to date the process of change and see what it looks like with something that is reversible. And then, as you said, it can be less expensive, at least in the short run, and the recovery from something like that is a lot easier. You mentioned insurance, and I think it's worth just very briefly touching upon that. Is that depending on the insurance company and the patient and the contract, a lot of these are actually covered by insurance. Unfortunately, we're starting to see more pushback with that. But there are certain companies that's interested. It's like the big tech companies that tend to support this. So like Apple, Facebook, Google, I've seen a number of patients from there. And then Starbucks coffee, actually their insurance is really impressive too with regard to covering this. And we do what we can do to try to make this a procedure that is or a set of procedures that's available for patients when they don't have insurance. But it's a lot of work, and so it's great when it is covered by insurance. It's great for the patient when it's covered by insurance.
Does that make you more likely to stage something for a patient if it is covered by insurance, or is that more driven by the procedures or interested in?
That is a good question, and that's really, I mean, the thing that drives staging things is the intersection of two things: safety and patient desire. So I've never met a patient who didn't want to do it all at once. And and what I've told patients is like, I think this is reasonable, but you have to choose the thing that you care about the least, and I'm going to do that last so long as it fits in the logistics of things. Because if I get to a point where we're pushing like 8.5 hours and we're looking at another hour or two of surgery, we're going to have to talk about doing that later. All of these patients I've worked with are so wonderful. They're so understanding. They're just grateful to be interacting with someone who respects them and is trying to, meet them where they are and see them as who they are. They understand that. I've never had someone who's had an issue with that. I've also never had to do that. But as we start to add more and more to what we can do, I think there are going to be times where we're going to have to pull out that safety card and say, we're going to have to address this later.
I think just for the sake of time stuff, and definitely I think something that we've seen here is that, maybe we'll come back and do like a 3-part series where we really address the upper, the middle, the lower third as an individual segment, because I think there's a lot more detail that we can go into. And so maybe treat this as a little bit of an overview and some, kind of framework for more stuff to come. And so, if our team would be willing to do that, I think that would be fabulous.
Absolutely.
Any last take homes on the topic that you'd like to leave people with in terms of some of these treatments? Maybe one or two that we haven't mentioned yet that at least want to give a shout out to. Anything else? Because I would say lip lift is somebody alluded to. I think that's become super popular. That's another easy one that sometimes can be done in the office, in the right patient. Sometimes can be in combination with other stuff. And so
like a buccal fat pad or
buccal
something.
fat pad is another one that can be done in the office that's helped. That's one where a combination of like a lip lift, buccal fat pad, cheek fillers can make a big difference. People from a cost recovery tends to be very reasonable. And the only reason I'm bringing it up is that I think that the patients Dr. Weinfeld's done that have had these larger surgeries get a dramatic, and they're super happy. But just from a personal lifestyle, that's not always in everybody's cars. And like, I'm planning this, but I need to plan this 2 years out from now when I'm going to have people to help take care of X, Y, and Z in my life stuff. So I don't want people to feel like if they can't commit, 3 or 4 weeks of recovery and so forth, that there's no options for them.
Right. And as far as trying things out too, like you were mentioning, Botox can offer some interesting options too with brow shaping or with masseter.
The masseters? That's a great
nut.
Maybe that's our behind the Bovie
There
nugget.
we go.
The masseter Botox. That's a great one. Maybe just for people that don't know, tell them what Botox to the masseters does.
So what Botox to the masseters does at certain doses, it actually decreases the size of the muscle because it paralyzes it, and so it just doesn't get that same use it does. So it actually shapes the face a little bit differently, gives you a little bit narrower of a gonial, or not gonial angle, but just narrower sort of cheek width there, or jaw width.
So if Celebrity doesn't act right, we can Botox his calf muscles and make his
That's
$1 million
right.
legs just fade away. Okay.
Chicken legs coming up. Chicken legs coming
unbelievable.
up.
Would you like to take us home with a quote of the day?
I will, but just right before that, I want to touch on a couple of key anesthetic
yeah, great.
thoughts from these cases. These are airway cases generally, or it's in and around the airway. So these patients, and I've worked with Dr. Weinfeld doing a ton of these, and they're longer cases, so they are intubated. I mean, these cases can run anywhere from 4, 5, 6, 7, even up to 8 hours sometimes. And, that is where he and I will have this conversation, or there's this conversation between anesthesia and the surgeon about, hey, how long is too long? Where did one part of the procedure go a little bit longer than what we were planning for? And then we kind of make some game time decisions while we're back there. And like you said, what's your least important thing? Sometimes that gets punted to another procedure day because it's not safe to continue doing anesthesia for that long in an outpatient setting. And the real reason that we're worried about that is because of airway edema and swelling in the airway that can happen during a long period of intubation, and that can just set the patients up for risk of having an adverse airway swelling after the procedure and after that breathing tube is removed. The other thing that we can have is a lot of time under anesthesia, those anesthesia drugs just build up in your system. So it just takes longer for those drugs to exit your system and for you to recover fully from that anesthetic. So just a couple of things to think about. It is not an immediate recovery. This is not like the 1 hour breast dog where you go in and you're ready to go really within 45 minutes of being done with your case. These are typically just a little bit longer recovery cases.
I think those are great points, and we didn't even get to stuff in the neck like tracheal shavings and other stuff that even have other rests. So maybe something for us to talk about in the future, because I think those make a nice difference for people.
The forgotten third. Well, I do think, I mean, this is a very hot topic in not only media, but plastic surgery and just all around, and people need to raise awareness, and they need to be mindful of these things. And I do appreciate the fact that you took a few minutes in the beginning to address nomenclature and the way that we talk about these surgeries in these patients. So definitely think this would be a good one to run back again. I do have a quote of the day, and I wanted to share it with y'all. It's from Dwayne The Rock Johnson.
Ooh,
I don't know if anybody saw me give the people's eyebrow, but our viewer base, I'm guessing, did not get that joke. But it's from Dwayne Johnson. Success isn't always about greatness. It's about consistency. Consistent hard work leads to success. Greatness will come.
No, I agree. Love it. I want to thank Dr. Weinfeld for leading today. This is, I think, a super complex, evolving, and hot topic, and I think it's something that definitely needs some more updates. Hopefully, he'll lead a few more discussions on this, because I feel
we'll
like
break it up into thirds.
We only scratched the surface, literally.
Literally, or force. Yeah.
Would you like to take us home?
Well, thanks for joining us on Plastic Surgery Untold. What do we got coming up in the next 4 sessions, or should we leave that as a cliffhanger?
We actually are breaking down a segment. We've highlighted this before, but a little med spa minute, if you will. We've never done a little rapid fire, so that's coming up next. So I think super exciting. Another special guest. You guys won't have to deal with celebrities, so you're welcome.
I'm out of here, y'all.
All right.
See y'all.
Bye. See ya.